Aim of my communication disorder is dysphagia, which is a swallowing disorder, and the cause of it could come from many different things. Dysphagia can occur in children and adults. Newborns with dysphagia may be unable to suckle and or ingest nutriments. As they age, infants may refuse food and develop unhealthy food preferences. In children, the cause of dysphagia could come from cerebral palsy, spina bifida, intellectual disability, and developmental delay, or cleft lip or palate. 22% of individuals over age 55 experience swallowing difficulties. In adults, the cause of dysphagia could come from a stroke, mouth, throat, laryngeal, or esophageal cancer, HIV, multiple sclerosis, medication and drugs, and spinal cord or traumatic brain injury. Dysphagia does not necessarily occur with all of these, but any one of these could possibly be the cause. The swallowing process occurs in 4 phases: the oral preparation phase, oral phase, pharyngeal phase, and esophageal phase. During the oral preparation and oral phase, drooling can occur because the lips are not sealing properly. Chewing may be impaired because of poor muscle tone or paralysis involving the mouth or because of missing teeth. During the pharyngeal phase, if the swallow is not triggered or is delayed, material may be aspirated or fall into the airway and eventually into the lungs. Failure to close the velopharyngeal port can lead to substances going into and out of the nose. During the esophageal phase, the complete bolus might not be transported from the pharynx to the stomach. Residue might be left on the esophageal walls, and that would result in infection and nutritional problems. The doctor makes the diagnosis for clients with dysphagia, and they are then referred to an SLP. The SLP is responsible for identifying, evaluating, and treating individuals with feeding and swallowing disorders. SLPs do not work alone. They are part of a team consisting of a physician, nurse, nutritionist, radiologist, dentist, neurologist, occupational therapist, physical therapist, respiratory therapist, and family members. An SLP, along with a team, obtains background information using techniques to assess swallowing and decides appropriate intervention and treatment strategies. Whatever the true etiology is, the outcomes of a swallowing disorder at any age include malnutrition, ill health, weight loss, fatigue, frustration, respiratory infection, aspiration, and possibly even death. If a child has dysphagia, the SLP will want to observe feeding as it occurs normally between the caregiver and client. The SLP will pay attention to if the caregiver is patient and attentive, if feeding takes place in a reasonably quiet environment, the position the client is in when eating or drinking, and how the client expresses feeding preferences. Careful observation and communication will help the SLP assess how best to improve the person's contributions. When treating a client with dysphagia, the objectives for the SLP are to improve the intake of food and drink and to prevent aspiration. The potential for success of swallowing intervention is largely determined by the cause of the disorder, the severity of aspiration, and the onset of treatment. In young children, treatment based on a careful diagnosis of the feeding disorder results in improved nutrition and generally better health. Early identification and successful intervention for swallowing disorders reduces the risk of aspiration and death following stroke, shortens the time patients need to stay in the hospital, and improves quality of life. The earlier you treat a swallowing disorder, the better the outcome. Treatment for dysphagia has been reported to be beneficial in at least 80% of cases. Some therapy techniques include the supraglottic swallowing maneuver. This is for individuals who do not fully close the glottis during swallowing. The purpose of this one is to close the airway at the vocal fold level before and during the swallow and to clear residue after the swallow. Another technique is effortful and double swallows. A hard and effortful swallow may be helpful for patients whose tongues do not retract enough to trigger pharyngeal swallow. Double swallows or multiple swallows are advised for individuals who retain some food in the oral cavity after a single swallow. Another technique is the Mendelsohn maneuver, which is useful for clients who do not have adequate laryngeal elevation during swallowing. A client is taught to hold the larynx manually at its highest point during the swallow. The client places a small amount of food or liquid in their mouth. They swallow while placing their thumb and forefinger on either side of 3 to 5 seconds during and after swallowing, and then they let go of the larynx. The SLP will determine which technique is appropriate for the client, and the treatment will continue. Patients that lack an intact swallowing mechanism because of malformation, surgery, or another cause may benefit from using a prosthetic device. Individuals who have had oral cancer and have had a portion of the soft palate removed may have a palatal obturator, a permanent or removable plate that helps close this area during speaking or eating. If techniques do not work, surgery to improve swallowing and prevent aspiration is sometimes needed. Some surgical procedures could be increasing the dimensions of the vocal folds or elevating the larynx. In severe cases of aspiration, the true or false vocal folds may be sutured, closed, and breathing will have to occur through tracheostomy. Clients that take more than 10 seconds to swallow liquid or food, or who aspirate more than 10% of either, will likely require non-oral feeding. An NG tube is placed from the nose to the pharynx, the esophagus, and finally the stomach. Liquefied food and water are inserted through this opening. In pharyngostomy, a feeding tube is inserted into a stoma, which extends into the pharynx. I found the modified barium swallow study to be very interesting. This procedure is used when clinical evaluation or screening suggests dysphagia and/or aspiration. Barium, a substance that can be seen on x-rays, is coated onto or mixed into food or beverage. A radiologist and x-ray technician use fluoroscopic equipment to observe the movement of the barium throughout the swallow. These views are video recorded for further analysis by the physician and SLP. The study provides real-time visualization of the swallowing process and is highly useful in determining whether the client should be fed orally or non-orally, what food textures are safest, and what types of treatment are appropriate.